Hello, I'm Dr. Anthony Wheeler, and I'm going to tell you everything that you need to know about pathology. You're probably looking at this image here to the right and saying to yourself, I know what that is. That's the coagulation cascade. And you're right. Actually, I'm going to create a very simple, easy to memorize image or table or graph or something like that, and I'm going to link it. That way you'll have a very easy way to understand everything that you need to know for the coagulation cascade, right? Because my goal is for you to have everything that you need to succeed, right? I got you, don't worry. But in today's talk, we're going to be talking about secondary hemostasis pathology. Make sure you have this book. It hits every single point as concisely as possible to help you do exceedingly well, rise to your full potential for step 1 and on medical school pathology, right? Because you know pathology serves as the backbone for all of medicine, right? There wouldn't be any medicine without pathology. You have to understand pathology to do great in medicine. Secondary hemostasis. Take-home point right here. The whole point of secondary hemostasis is to stabilize the platelet plug. The main end product of the coagulation cascade, is thrombin. That's the whole point, for the most part. To the right, we have an image of the coagulation cascade. If you can remember that the extrinsic pathway involves factor 7, and the combination of the common pathway includes 10, 5, 2, and 1. Everything else is on the intrinsic side. If you can remember that for now, you're light speed ahead. So secondary hemostasis. Secondary hemostasis utilizes the coagulation cascade to stabilize the frail, weak, little platelet plug. The fibrinogen in the platelet plug is converted to fibrin by the thrombin produced by the coagulation cascade. The result is a stable platelet-fibrin thrombus when fibrin is cross-linked. A lot of the coagulation cascade factors are produced in the liver. Certain coagulation cascade factors require potassium, and those include factor 2, factor 7, factor 9, and factor 10. Also keep in mind that protein C and protein S are also dependent on vitamin K, but these proteins facilitate platelet breakdown and promote bleeding. Now you might be asking yourself, why do these factors and proteins need vitamin K? Well, that's because the enzyme that does gamma carboxylation, as you remember from biochemistry, it utilizes vitamin K to produce this end product via gamma carboxylation. Now, factors 2, 7, 9, and 10, protein C and protein S, you will be asked about them. They require vitamin K. You'll highly likely be asked several times about those. Also, there is a compound called Warfarin that was created in Wisconsin, actually, by the Wisconsin Alumni Research Foundation. That's how it gets its name. It was initially used as rat poison, caused the rats to bleed out in New York subways. Some wise person said, hey, let's use this on humans to keep them from clotting. And the rest is history. So warfarin is used to actually impact that gamma carboxylation. Let's talk about activation of the coagulation cascade. That requires a number of things, which include exposure to the activating substance, tissue thromboplastin, which activates factor 5 via the extrinsic pathway, should be factor 7. Double check that. updated version will have whatever is correct. Let me know. Subendothelial collagen activates factor 10 via the intrinsic pathway. Phospholipid surface of platelets also, and calcium derived from the platelet-dense granules, right? These are ways that the secondary hemostasis is activated via the coagulation cascade. Disorders of secondary hemostasis are typically the result of an aberrant coagulation factor. Clinical features of disorders of secondary hemostasis include deep tissue bleeding into muscles, bleeding into joints, hemarthrosis, prolonged bleeding after minor traumas, or prolonged bleeding after surgery, right? These all make sense. Laboratory studies used to assess disorders of secondary hemostasis in particular include Prothrombin Time, partial thromboplastin time, bleeding time, and mixing studies. Prothrombin time measures extrinsic factor, should be 7, and common factors, 5, 10, and fibrinogen pathways of the coagulation cascade. Good thing you have your book because you're making notes. Partial thromboplastin time measures intrinsic, such as factors 10, 11, 9, and 6, and common factors 2, 5, and 10, right? Double check that. And fibrinogen pathways of the coagulation cascade. Bleeding time measures the time it takes for bleeding to stop. Mixing studies check for missing clotting factors. So this image here to the right is showing the growth of a cancer. It's just a cartoon. But future oncologists out there and pathologists, keep in mind that cancers actually secrete a number of cellular modulators and immune modulators that impact the way normal physiology works. For example, this cartoon is signifying that this cancer is producing something that disrupts the platelets. And when that happens, those platelets release chemokines and cytokines that promote angiogenesis, causing the development of small blood vessels via angiogenesis, which produce blood vessels that lead to the cancer promoting its growth. Isn't that crazy? All the budding radiologists out there knows what's happening in this image here to the right. We have a patient with Hemophilia A and some swelling picked up on the x-ray. Hemarthrosis, right? Soft tissue swelling. Hemophilia A is a condition that results in excess bleeding. Hemophilia A is due to a genetic factor 5, 6, 7, 8, 9 deficiency. And my editor clearly doesn't understand Roman numerals. I'm going to have a chat with him. Anyhow, Hemophilia A is due to a genetic factor 9 deficiency. Hemophilia A is X-linked recessive, which is why it predominantly affects men. Hemophilia A may occur as a result of a novel mutation, i.e. de novo, just randomly, without any prior family history. But in general, it's X-linked recessive. Common symptoms of Hemophilia A include hemarthrosis and post-surgical bleeding. The degree of the insufficiency determines the clinical severity. Now look at your patient here to the right. Look at the purple regions on his forearms and upper arms, right? This patient has Hemophilia A. His was acquired Regarding laboratory findings of hemophilia A, you will see an increased PTT, an increased bleeding time, normal PT, normal platelet count, and diminished or absent factor 8 levels. In mixing study, factor 8 corrects clot formation. Hemophilia A is treated with recombinant factor 8. So is it factor 8 or factor 9? I'm going to give you a second to figure that out. You could pause it here. Sometimes when you look things up yourself, check, trust, and verify, it serves you better. I used to work in corporate as an engineer, and there was a phrase that said, trust but verify. Like, you believe what you're told, you believe what you hear, but verify it. Yes. Anyhow, we have a image showing various smooth muscle actins and how the endometrium's affected. Interesting. This is just signifying that factor 8, not only is it a coagulation factor, but it's also used for visualizing certain architectural features in cells under a microscope, such as, in this case, SMCA, or, for example, megakaryocytes. Pathologists use factor 8 to visualize megakaryocytes under the microscope. Let's talk about hemophilia B. Hemophilia B, factor 9. Duly noted. Now, hemophilia B is a condition that results in excess bleeding. Hemophilia B is due to a genetic factor 9 deficiency. Factor 9 deficiency for hemophilia B. Hemophilia A is 8. Hemophilia B is 9. A is 8. B is 9. Now that we have that sorted, hemophilia B has symptoms and labs similar to hemophilia A, except factor 8 is normal in hemophilia B. Factor 9 is diminished or absent in hemophilia B. Hemophilia B is also called Christmas disease. I wouldn't want Santa bringing that to me. Either way, in a mixing study, factor 9 corrects hemophilia B, right? If you think about it, what's abnormal with hemophilia B? Abnormal factor 9. So if there's, some company out there that makes factor 9 that works, and you put this person's plasma or blood or whatever in a tube with this properly functioning factor 9, you should have some sort of mixing study that shows, hey, there's a clot forming, right? Because we replaced what was malfunctioned. Therefore, hemophilia B is treated with factor 9. On the right side of this image, all the radiologists are looking at this and they're saying, there's diffuse ground glass opacities in the bilateral lung fields. And this can happen in patients with a number of conditions, among which hemophilia B is included, due to diffuse alveolar hemorrhage. Regarding coagulation factor inhibitor, there may be acquired antibody production that affects the function of a specific coagulation factor. And the most common coagulation factor inhibitor is anti-factor 8. Anti-factor 8 has the same clinical and lab findings as hemophilia A, except the mixing study results. In anti-factor 8, due to an inhibitor being present, the PTT does not correct when a patient's plasma is mixed with normal plasma in a mixing study. Now this is important. Everything else was important, but this is important. You must know von Willebrand disease. Von Willebrand disease is a condition that results in excess bleeding. Von Willebrand disease is due to a genetic von Willebrand factor deficiency. Von Willebrand disease is the most prevalent hereditary coagulation disease. On the right here, we can see some inheritance patterns. Now, in general, there are 5 different types of von Willebrand disease that you will need to know if you're going into pathology. Otherwise, you can just remember von Willebrand disease. And for purposes of step 1 and your coursework, you don't need to know that there's 5, but you'll probably just remember that anyway. There are numerous subtypes of von Willebrand disease that result in both quantitative and qualitative abnormalities. The autosomal dominant type of von Willebrand disease, i.e. the one that's tested the most, has lower von Willebrand factor levels and is the most prevalent type. With regards to von Willebrand disease, there's usually the clinical symptom of moderate mucosal and cutaneous bleeding that shows up as the initial symptom. There is poor platelet adhesion caused by low von Willebrand factor, right? And if the platelets can't be stuck on, then guess what's not going to form properly? That stabilized clot, right? So you're just going to have bleeding that keeps occurring. On the right here, we have the inheritance pattern for von Willebrand disease. Usually, for all intents and purposes, the one that you need to know about is the inherited one that's autosomal dominant. Now, laboratory findings for von Willebrand disease that you need to know about include increased bleeding time, and everything else is normal for the most part. So increased bleeding time and everything else is normal. What's normal? The PTT is normal. The PT is normal, and the platelet count is normal. An aberrant rhistocetin test is one in which there is no von Willebrand factor, which results in platelet aggregation being induced by rhistocetin. So you will see that. Desmopressin is used as treatment to promote the release of von Willebrand factor from endothelial cells, Weeble Pallady bodies. Also note that desmopressin is an antidiuretic hormone analog. Now, what happens when there's vitamin K deficiency? Well, we're going to get into that. Vitamin K is needed for the production of several components involved with coagulation. Do you remember them? Vitamin K deficiency results in abnormal coagulation factor production of certain coagulation factors. Coagulation components affected by vitamin K deficiency include factor 2, 7, 9, 10, protein C, and protein S. Gamma carboxylation is required for the aforementioned factors and proteins to function. Vitamin K gets activated by epoxide reductase, which is present in the liver. All newborn babies receive a prophylactic vitamin K injection in America at birth to guard against hemorrhagic illness. Now, why is this? Well, that's because the babies don't produce vitamin K early on, right? Because it's actually the gut microflora that utilizes what we eat to produce vitamin K. So due to the lack of gastrointestinal colonization by bacteria in the newborn that normally manufacture vitamin K, deficiency can be noted in infants. That's why we give the babies the vitamin K injection at birth. Keep in mind that gastrointestinal tract bacteria that produce vitamin K may be disrupted by long-term antibiotic therapy. Also, malabsorption may cause a lack of fat-soluble vitamins such as vitamin K, leading to clotting issues. Where do we see malabsorption of fat-soluble vitamins? Obviously, if there's a nutrient deficiency, an anorexic patient who's not eating properly, some sort of abnormal diet, celiac disease. Other issues of abnormal secondary hemostasis. The effect of liver failure on coagulation is monitored by the PT. Liver failure can result in decreased synthesis of coagulation factors and decreased activation of vitamin K by epoxide reductase. Large volume transfusions can dilute the coagulation factors, which may cause a relative shortage of coagulation factors. Interesting. And with that said, we're at the end of today's lecture. This presentation is officially concluded. Bravo. You did great. You know a lot. You know so much. Wow. Can you believe all that you know? You're so smart. You know a lot. You're going to do great. Keep up with your studying and keep making your way through. Review what you need to review. Do those practice problems. Make sure you're working on what you need to work on. And I'll see you next time. Good luck. Happy studying. See you later.